Good afternoon. I just want to thank the organizers and the sponsors again for setting up this wonderful session, despite the rather ominous name of the lecture hall. It's the Guernica room. I think it's turned out much better. So my name is AZAD MASHARI. I'm an anesthesiologist from University of Toronto, and I work with Joe Fisher, who unfortunately for you, but fortunately for me, couldn't make it today. So I get to be here and enjoy the hospitality and the experience. So this last session was set up as a bit of a, I guess, head-to-head, and I have the unfair advantage of going last with the rival system. So this is another alternative system for delivering volatile anesthesia, primarily in the ICU, but also potentially for field applications as well. Everything here is under a Creative Commons license. And in terms of a statement of interest, I wasn't offered any shares, but 3 of my co-authors are shareholders and were involved in the development of the MADAM vaporizer, which is the only commercialized part of this setup. Thornhill Research Inc., which manufactures the device commercially, also funded this investigation, and I will not be discussing any off-label applications. So the clinical challenge, sort of what started this work for us was that about half of the authors on this study are ICU physicians and cardiac anesthesiologists, and we're interested in applications of volatile anesthesia in the ICU. But there's also a significant interest for field use, both in low-resource settings and disaster zones. And in fact, the MADAM vaporizer originally was developed for military use as part of a self-contained portable ICU. There's also applications inside the hospital but outside of the operating room, so for procedural sedation and medical imaging and other sites where you may not want to drag a whole anesthetic machine with you. The technical challenges that are presented by using volatile anesthesia outside of the operating room are essentially as follows. So you want to have a system that is highly efficient, both to minimize cost and to minimize occupational exposure, especially in areas that may not have the ventilation that the operating room typically has. You want fine control of the dosing. You want it to be precise and easy to use. You want it to be usable in your full range of patients, including the complex ones, so limitations on tidal volume can be a factor. And furthermore, you want all these features to be quite robust against changes in circumstances, changes in other equipment in the situation. So you want the device to be compatible with a wide range of ventilators and ventilation modes. You want it ideally to be portable, low cost, and usable by a range of care providers. In terms of the state of the art for achieving anesthetic efficiency for volatile anesthetics, there's basically 2 strategies that you're all familiar with. There's low flow and anesthetic reflector. In low flow systems, the VA consumption is proportional to a fresh gas flow, and which is the source of its main limitations. So low fresh gas flow isn't always possible in other settings, especially in the ICU with high flow ventilators. In addition, if your vapor is also being delivered by fresh gas, then you have the trade-off between how fast you can increase the dose versus how efficient your system is. Now this has been addressed by systems with direct injection, like the Zeus Diva that delivers the anesthetic directly, and the MADAM vaporizer as well, which are both direct injection systems, which do not rely on the fresh gas flow to actually increase the dose. Anesthetic reflectors liberate you completely from fresh gas flow, so your efficiency and your dose changes are unrelated to the fresh gas flow, but they have other limitations. So you've already heard about the CO2 retention concern, which limits low tidal volume ventilation, which is a factor in pediatric patients or for lung protective ventilation in patients with severe ARDS. There's also issues with the Anaconda in terms of the control of the syringe pump and dosing. And then furthermore, as came up in one of the questions, the issue of ergonomics in the ICU. Both the Mirus and the Anaconda require bulky equipment near the patient's head, which is a sort of high-priced real estate in the ICU. Lots of other interventions need to take place there. There's other equipment, NG tube, suctioning, and which can also not only can these devices impede those procedures, but those procedures can potentially cause device disconnections and malfunctions of the device. So our basic idea was to combine target-controlled direct injection with a reflector, so much as has been done in the Mirus, but to also add a CO2 absorber into the mix. So the idea that this would give us both the fine control of a target-controlled injection system. We would still be free of fresh gas flow in terms of efficiency and dose changes, and the CO2 absorber would prevent the CO2 retention issue. So it wouldn't have any limitations on tidal volume or ventilation settings. And we could do this using standard equipment components that are widely available and already approved for human use. And this is a picture of our basic setup. So on the right is a standard circle system, which is what we happen to use for this experiment, but any ventilation circuit will do. On the left is what we call the rival circuit. So it's a loop that contains a CO2 absorber and an inline vaporizer. And these two loops are connected by the anesthetic bridge, which contains the filter. So the expiratory paths and the inspiratory path are both marked. So the inspiratory path is in red, and the expiratory path is in blue. And one feature of this kind of setup that we didn't appreciate immediately but came to light later was that regardless of what your fresh gas flow is on the ventilator side, the flow inside the rival loop is essentially constant and equivalent to your minute ventilation. This is how we assembled the reflector bridge. We just took an anaconda filter and sandwiched it in an old HME casing just to get the 22 millimeter connectors on both sides. And this is just the schematic of the inline vaporizer that we used, the MADAM. So you set the target inspired concentration on the dial at the top, number 8, and the device sits on the inspiratory limb, and it measures the flow and the concentration of anesthetic coming in and just tops it up to reach the target. But any other inline form of vapor administration would do, as long as you're happy with the control parameters that you're allowed. So just a recap of the setup. So as a proof of concept, we tested this in 6 Yorkshire pigs, weighing between 15 and 20 kilograms, and we set the inspired target concentration to 2.5%. We've set the ventilator to have a baseline end-tidal CO2 of 35 to 40 millimeters of mercury, which typically worked out to tidal volume of 10 to 12 milliliters in these pigs. These pigs tend to have higher metabolic rates than humans and are quite prone to pneumothoraces as well. So their ventilation is a bit tenuous. We measured steady state sevoflurane consumption, which is recorded by the vaporizer that we have, and we varied the fresh gas flow on the ventilator side from 1 to 4 to 10 liters per minute, and we measured steady state with and without the reflector in the bridge. And when the reflector was in place, we also measured CO2 levels with and without the CO2 absorber in the rival loop. And the hypothesis was that we would be getting the VA consumption, the efficiency of the reflector without the CO2 problems. This is the setup. So you can see the rival loop is here. So this is the bridge. So the reflector will be sitting here. This was taken in the no reflector condition, so the reflector is out of the circuit. So this is the ventilator loop. This is going to the CO2 absorber, to the vaporizer, and to the Y-piece for the patient. And that's just another phase-in monitor to double-check our concentrations. And these are the results for the anesthetic consumption. This is without the reflector in the bridge, and the bottom one is with the reflector in place. And you can see that essentially with the reflector in place, anesthetic consumption is unrelated to fresh gas flow and significantly lower than with the reflector in place. That wasn't surprising. What surprised us was that even at 1 liter per minute, there was almost a 50% reduction in anesthetic consumption. And the results for CO2. So again, these are both with the reflector in the bridge, but one has a CO2 absorber and one does not. So this is without the CO2 absorber, and this is with the CO2 absorber. And we found that reliably, both inspired and end-tidal CO2 concentrations increased by about 15 millimeters of mercury, or 2 kilopascals, when the absorber was removed, which works out to about 1 liter per minute loss of effective ventilation, with a minute ventilation of 3 to 4 liters. And once we put the absorber in place, the CO2 was essentially eliminated. This is the same graph, just with a kilopascal scale. In terms of dynamics of gas delivery with the MADAM, this is just a sample from a single pig showing sevoflurane concentration versus time. And the concentration target was changed from 1.2 to 2.5 at the arrow. And you can see within about 4 breaths, the target concentration is reached. And the end-tidal concentration plateaus within about 20 seconds. So to summarize, we're comparing some representative systems here in terms of the criteria that I set out at the beginning. This first part of the table looks at systems that are designed for operating room use. So we're comparing the GE ASIS, the Zeus Diva, and the MATM just on a circle system. The latter two use direct injection, while the first one, well, the GE ASIS uses fresh gas flow to deliver the vapor. And as such, dose change rate is not independent of FGF as it is for the Diva and the MATM. They all three have target control, but the variable that they control is different. So the GE uses the traditional Untitled control. The Zeus Diva, as I understand it, correct me if I'm mistaken in this, I'm not an expert on the Diva, but it controls a combined sort of circuit and lung concentration, whereas the MATM controls the inspired concentration. They're pretty comparable. Obviously, they can ventilate any tidal volume. The modular nature of the MATM allows it to be used in the field with any other ventilator, including a bag mask. Looking at systems for ICU use, the Anaconda, the Mirus, and the Rival. So all three have direct injection into the circuit, so none of them rely on fresh gas flow, as we already mentioned. So in both cases, both the efficiency and dose changes are independent of the fresh gas flow. The Mirus and the Rival both offer some form of target control for the dosing, and I wasn't sure about the ability for field use for the Mirus, but essentially the key distinguishing features of the Rival are, one, its low tidal volume, and two, the improved ICU ergonomics, because you don't need to have any additional equipment at the patient head. All of the equipment can sit on the ventilator side, or essentially anywhere in the room where you have space, as long as you're happy with the length of tubing. So some caveats, obviously, all the components here have been approved for human use, including the vaporizer, but this was a proof of concept for the setup in 6 pigs. So we obviously need clinical validation in humans. We looked at steady state concentrations, but there are some upfront efficiency costs in this system because you have to saturate that second CO2 absorber with anesthetic. So for a short case, it may not be as beneficial, but if we're talking about ICU long-term sedation, that makes less of a difference. We're targeting inspired, not entitled concentrations that people are more comfortable with. And furthermore, theoretically, this can be used with any ventilator and any tidal volume, but that needs to be actually checked and validated clinically, which we haven't yet done. But in conclusion, combining an anesthetic reflector, an inline vaporizer, and a CO2 absorber in this fashion provides you with robust high efficiency independent of fresh gas flow, provides you with fine control, avoids CO2 retention, so there's no theoretical limit on tidal volumes, and improves the ergonomics for ICU settings. And it can be assembled from commonly available low-cost components, so the only costly component is the vaporizer. Otherwise, it's assembled out of standard parts. And this work was just accepted in ACTA. It's currently in press. I just want to thank again the organizers and the sponsors and my co-investigators and support staff at the Animal Care Facility at the Peter Gilligan Center for Research. And I also want to thank Dr. Steve Isco and the anonymous reviewers who provided very thoughtful feedback on the manuscript, and I suspect some of them are probably in this room. So thank you.
Okay, thank you for this nice, mainly experimental work so far. But any questions on this from the audience?
Sorry to dominate. Very nice presentation. I'm sorry Joe's not here. When you showed the efficiency data, after how long? At some point, the charcoal in these reflectors become saturated and they just become a slow pipe. After how much anesthetic was that you showed that efficiency, or is it just at the beginning?
We didn't actually hit that point. So we actually used a single reflector throughout these trials, and we never hit that point to actually have
so you never got to the breakthrough point.
Decline in the efficiency. And you can see the standard deviations are quite low. So even there was no significant difference between the earlier pigs that we ran and the later ones.
And then the other question, so all this extra hoses and things, I would imagine on kids or somebody with stiff lungs, at what point are you just ventilating hoses and not really moving gas in?
The hose line here was done for convenience, for logistics, but really there's no functional need to have that much hosing. Okay. That as long as you can just decide based on your ergonomics and your patient needs how much of the hose is acceptable. But the hose can be minimized to a total of about 30 centimeters, and if you actually custom build the CO2 absorber enclosure, you can reduce that even more. Like if this is built into one package.
But then you're impinging on that that tight real estate around the face, the shorter you make that.
Yes, so that's the sacrifice, but you have control of that.
One question. Did you work on the question how you can control FiO2? So
We didn't.
Yeah.
We didn't control the FiO2 with this system, and the so the short answer is no. But I think you can control the FiO2 in the ventilator circuit because there's no rebreathing of the gas in the rival circuit. So actually, whatever FiO2 you have in the ventilator circuit will be the FiO2 that the subject will be getting. So as long as your ventilator, so if you want to have an FiO2 control, if you're using a ventilator that has oxygen, that has expired oxygen control, or they can probably add a bit of a delay, but I think in a long-term sedation setting, it's probably less of a factor.
Okay, thank you. Yes,